All right, good morning and welcome to Friday Chalk Talk. My name is Martin. I'm your moderator for today, and this morning's topic is going to be an invitation to the inner world because as Yoni has told me before, it's relevant, it's present, and the degree that you go into your own inner world sets the limit for how far you can go into your patients. So today I have the pleasure of introducing two guests. Our first one is the Rabbi Yonason Meadows. Yoni may not admit this, but I know him to be the aspirational target for chaplains to work towards in their profession. Not laughable. It's true. I mean, you hold this deep knowledge of behavioral health. You've served as a chaplain at Unity Point and Advocate Aurora. You're twice ordained as an Orthodox Jewish rabbi. You have a master's in social work, and you serve as CPE educator across multiple systems and multiple states. And on top of all of that, Yoni is also a dear friend and a mutual sounding board in our weekly, monthly dates. And so Yoni, the thing you may not know about him is he has some funkalicious style with his tie-dyed shirts and his bandanas, which I'm disappointed you didn't wear today. But welcome, Yoni.
Thank you very much.
Yeah. Second, we have Jennifer Greenwood. Jen is a hospice and palliative care social worker. She has recently joined our team here at St. Luke's. She also has a background and expertise working with mental health, and she brings our team invaluable support in working with trauma, coping techniques, debriefing, and viewing encounters with a different lens that complements our clinicians. So welcome, Jen. Today is going to be part one of a two-part series, and our speakers want you to know that questions should come at any time. You don't even have to put them in the comments section. Just unmute, interrupt. This will be more of a group discussion than anything else. So with that, I hand the mic over to you two.
Well, good morning, everybody. After much discussion and review, I hopped on with Yoni of discussing this topic because it is important for us as providers to understand our own inner selves and why we respond the way that we do, and hopefully our understanding of ourselves, our coping skills, and thus making the patients have a better experience and interaction with us overall.
Thank you, Jen. And part of what I'd like to begin with and to emphasize is some of the things that Jen and I are going to be talking about are the practical nature of this, because psychodynamic psychology, or depth psychology, as it's often known, does deal with a lot of deep philosophical and spiritual psychological concepts. Mm-hmm. But one of the places where we're beginning is the simple fact that as clinicians, if we're providing care for others, the degree to which we fully understand the people we're trying to provide care for, in addition, as Jen and I will be talking about, if we understand ourselves, bring ourselves to every encounter, mm-hmm. the degree to which we actually understand this meeting of two people, the degree to which we'll be able to perform accurate assessments and effective interventions. Mm-hmm. So as much as Jen and I love to talk about the theory, and we do, mm-hmm. We're beginning with this conversation to be about the fact that all of us here on the call, in one way, shape, form, or another, are all practical clinicians providing care.
Mm-hmm. And I hear too from patients, family members, sometimes they have really great experiences with providers, and some don't. So sometimes it's kind of knowing ourselves, because a lot of this starts our ID, ego, and superego all start when we are infants, And thus, as we grow older, due to seeing and having life experiences, influence our personalities, the way we see things, the way we do things. And sometimes as we get older and we are taught in our professions, I know I am a far different clinician than I was when I first started out. Is an understatement. Much more in tuned into thinking about how can I come across as a caring, actively listening provider that shows empathy, that shows care, that shows that I am present. And that's the biggest thing, I think, for a lot of our patients, is being understood. They're afraid of being judged. I hear that a lot. And just having an open mind going in and meeting our patients, of meeting them where they're at.
Indeed. And I think everything that Jen is saying, I think before we proceed, I wanted to give a quick definition of the topic to sort of set the stage. In addition to which, I'm going to, the structure for today and for next week. Today is a general overview of psychodynamic psychology, or depth psychology, to talk about the broad brush concepts. And then next week is going to be a more specific discussion of what are called coping mechanisms, defense mechanisms. These are largely unconscious strategies, tactics that our hearts, minds, and souls use, usually without asking us consciously, in response to something in our environment as a means to survive. And this is something that's present in all of us. It's Jen and I agree that it's important to usually get away from positive or negative. It's simply a recognition of what's there. And next week, we're going to be talking about some of those coping mechanisms in more specificity. But so to talk about psychodynamic psychology, and Jen can jump in to agree or disagree. But the way I define it, this is in distinction to the behaviorist schools of psychology, of which cognitive behavioral therapy, CBT, is probably the best known. So psychodynamic psychology, as implied by the name, is any branch of psychology that understands to be relevant and important the elements of our psyche, which, beginning with Freud, the psyche is not the intellect, the cognitive mind. It really the combination of the mind and what Freud actually did talk about in German, Seele, as the soul. It's actually a misconception that Freud was mind. He was not. So the psyche is our total inner being. And so this is any branch of psychology that believes that what is unconscious to us, which, like an iceberg, is most of what's below the water, which is most of the iceberg. What is unconscious to us helps shape who we are and helps determine how we see the world, and then what we do, how we interact with that world. The behaviorist schools of psychology, which are much more in vogue these days, intentionally say we're not looking at the unconscious. We're not looking at all of this, what in social work is called latent content, all of this material that is not visible to the naked eye, so to speak. We're going to be looking at behavior and how to manage it. That has its place. But that's not what we're talking about today. Today, we're talking about the branches of psychology that try to look at the totality of our being.
Which a lot of, especially mental health, preferably like using CBT. It's, something that, changing the behaviors, recognizing triggers and how to manage those unwanted behaviors, thoughts. And that has its place in a person's overall what's going on with their life. But psychodynamic therapy or theory is pretty much taking views from all the different, Freud being the Yoni was saying he's the grandfather of this all, describing the ID, which is kind of referring back to the iceberg, is at the very bottom. And it's something that we learn, it's pretty much infantile to about 3 years old. And then the superego develops, and we're learning things. We're absorbing all of this different information and storing it. And then, which goes into the ego, which the mediator, so to speak, and the reality on the gratification of things.
So psychodynamic psychology began with Sigmund Freud, with the id, the superego, and the ego, and then was later developed by other clinicians. Some of the most famous names would be Carl Jung, Karen Horney, Alfred Adler, and then what we call the Object Relations School, Melanie Klein, Donald Winnicott, Heinz Kohut, and then I would say culminating in Erich Fromm. A lot of the later schools started to take this more in a collective view, as opposed to Freud and Jung, who were really much more looking at the individual. And they broadened out this look at these unconscious drives, but everything came from that beginning of a recognition that what you see is not all of what you get. And speaking as a Jewish person, part of what's flowing out of my culture is this deep recognition that what is on the surface, of course, exists, but there are many levels below the surface to everything. And all of that exists simultaneously in real time. And all of that influences everything else in that system, whether that's an individual or something much broader. And I wanted to trace back to the quote that Marty actually began this talk with, a favorite quote of mine. And this was a quote, Carl Jung, Carl Jung, in speaking to a group of Swiss clergymen, Swiss ministers, said to them, please know the degree to which we are able to enter into a deep understanding, the inner world of our patient, is directly proportional to the degree to which we have done that work and that understanding and investigation within ourselves. If we don't know ourselves, which we're bringing into the room every time we provide care for somebody, we cannot, there's no shortcut. We can't then have a real understanding of who we're trying to provide care for. And then again, the question becomes, do we even know who they are? And do we even know what they want or what they need?
And two, it's asking questions, using eye contact, which depending on their cultural, knowing their cultural background, and be able to recognize when it's appropriate to look someone in the eye versus not looking someone in the eye due to, it doesn't show respect, and so forth. And one of the things I think is a good reminder for all of us as practitioners is going in and talking with, listening actually to our patients first, getting to know the who of who they are, what do they feel, what have they heard in their point of view, because often we go in with our own agenda, which is completely off base of what is on the patient's mind or in the forefront of their worries, their anxieties. And sometimes there's too miscommunication where, you know, you hear it time and time again. They've seen so many different providers in one day that they've heard so much information. And some of it they remember and some of it they don't. And so it's kind of getting to know our patients first, taking that time to get to know them, and to ask, you know, what is it that we should know about them, is really important. It shows that we care. It shows that we are genuinely interested in what they have to say and what their concerns are.
And also to ask ourselves, to try to be empathic, try to put ourselves in their shoes, so to speak, and to really wonder, always be curious about everything, but to be curious about, if we were in their position, what would we need? What would we want? But another starting point for psychodynamic psychology is something that actually has been clinically studied in many studies dating back all the way to the 1930s, and the dodo bird hypothesis. The dodo bird hypothesis from Alice in Wonderland, where Alice in Wonderland sees a race around the lake with the dodo birds, and she asked, well, who won the race? And the answer was, everybody runs and everybody wins. The dodo bird hypothesis is the idea, and it's been subsequently shown to be true from studies, that with some limited exceptions, and one of which I'll get to in a second, it's been shown that by far the most important aspect of whether or not a therapeutic intervention is going to be successful is the nature of connection, the level of connection, and the level of trust between the practitioner and the patient versus whatever modality happens to be used. The level of modality, or which modality is used is largely irrelevant. Mm-hmm. In the face of, does the patient actually even connect to the practitioner? Is the practitioner actually connecting to the patient? And does this patient feel this is someone that can help them and is going to work with them? One big exception to this that has been shown clinically is addictions. Because addictions, because you're dealing with oftentimes a behavior that is pathological, that is damaging to the person, there it's been shown clinically that CBT, that behaviorist therapy, initially as the first step, is really indicated. Because if someone is doing heroin and is threatening their life, first they need to stop doing heroin. Now, once you've achieved that behaviorist result, if we don't follow up, and this was a head of addictions for a major hospital that I'm good friends with, said, if we don't follow up and then try to find out why they were doing the heroin in the first place, a psychodynamic approach of understanding, then you may stop the behavior for a time, but they're going to go back to that drug, or they'll simply become addicted to something. You haven't addressed the root cause.
Mm-hmm. And it's kind of the Band-Aid effect. CBD, after working with patients with yes, CBT can work. It does. It takes a lot of, it depends on whether or not they're ready to change, ready to make the choice to better themselves, not for anybody else. Because very often we'll hear, I'm doing this for my kids, I'm doing this for my mother. And that only lasts for so long. Those are often the repeat readmissions that we would often get. If we didn't get the idea across and the acceptance of heroin is the Band-Aid, the numbing of to numb their thoughts, feelings,
Experiences.
yes. And then they just go. They don't like to feel out of control. So they use the heroin to kind of, it puts them at peace. They have less anxiety. For them, it's a win-win. But after time, it eventually catches up to them, where they sometimes get into legal problems, and then they're back in treatment. And it never works out really well when someone is mandated to do something. I know, mandation does not work very well in a therapeutic world at all. So once getting patients to that point of, okay, you're right, this isn't helping me, but getting to deeper, and often we would try to do this to some degree in groups, of getting to the whys. How did you start? Why did you start? And often it's due to a conflict at home, unrealistic expectations that they have among themselves, members have of them, not living up to mom and dad's expectations. And the list goes on.
Mhm.
And so, and that takes time, and, their recognition of, oh, these are the reasons why I'm reaching out to numb myself and to cope. And they begin to recognize the different things that have happened in their life, the traumas, the treatment from those that loved and cared about them, had a negative reaction. And sometimes too, we see that in our practice where, someone we remind them of someone important in their lives, and we trigger them. And no one knows that until we try to get to know somebody. But with that, if we do see that, then it's us being self-aware. And we'll go into this more next week. But being aware of us triggering them, because we don't want to cause any further trauma to our patients. We want to be able to stop and listen, be present, listen to their words, the words that they're saying, and not necessarily leading them to putting words in their mouth, because I definitely wouldn't want someone speaking for me. And I think patients really, when they've heard a recent diagnosis, their thoughts are bouncing all over the place. And they are just trying to, they may already have chronic conditions, and now this is an additional one. And like cancer, for instance, is a huge one that I know I see a lot, that patients don't do. And so they go through various stages of trying to figure out what life is going to look like.
So it all begins, I think, one important difference of the psychodynamic schools of psychology versus some of the others is what I like to talk about in chaplaincy education, is something I'm talking about constantly, which is process over product. That if we go in as clinicians with a preformed idea of the patient's pathology, and our job is to go in there, assess that pathology, and to fix that problem, and then to go out. So it's like helicoptering in. The difference of that approach versus the psychodynamic approach, which doesn't even necessarily pre-pathology, but says that every human being deserves to help themselves and to help others come to a deeper level of understanding and of trying to go towards what Carl Jung called individuation, which is integrating the parts of ourselves that we are proud of, that we're comfortable with, and the parts of ourselves not. But all of that makes up who we are. When working with patients from a psychodynamic perspective, we're beginning from the assumption that whatever they're doing, and this actually dovetails with trauma-informed care, that whatever they're doing is happening for a reason. It fills a need. That need or that reason may or may not be healthy ultimately, but it's there. It's not random. I'm not a big believer in random of really any sort. It's there for reasons, and the more that we can understand that we're encountering a fully formed human being who is more than their problems and has done things for reasons, and we're there to help that person instead of imposing our own answers, to help that person find their own and to understand who they are and how they got there. That ultimately, clinically, is going to indicate a much better level of success, however that's construed down the road.
Can I ask you a question, Yoni? Or
Yes.
maybe make a comment? Every hospital has those really tough cases where the primary team sometimes doesn't even know what to ask. They'll just put in a consult and it says help. And sometimes those consults go to ethics, sometimes palliative care, sometimes chaplaincy, sometimes psychiatry. And the thing that all of those have in common is that many of those are about relationships and understanding the why and getting a deeper understanding of that person, and then helping the medical teams understand that why. It fits perfectly with what you're sharing.
Yes.
Yeah.
Both Jen and I can think of, like off the top of my head, several clinical examples of when I have encountered exactly that. And that is a lot of what the psychodynamic approach can really bring to the table, is having the clinical knowledge, skills, and experience to be aware of what's going on inside of ourselves, and that's always relevant, to be better able to be aware of what's going on in the other person, and then to have the skills and the willingness to create an empathic bond between the two.
Because everybody has their own bias of when they hear psychology, psychiatrist. Most likely a lot of patients I know have had bad experiences. And so they're, I think I saw Rachel pop up where patients don't have, was it a good mental health? Just they have their own anxieties, severe mental health issues that kind of prevent them from having a clear picture, or thinking the worst. And sometimes coming in and doing a simple introduction. Sometimes I just introduce myself as Jen, and I'm here to get to know you more. And I often get more in I rarely get a response where I don't want to talk to you, because they are usually more than happy to tell me about themselves, tell me about what they want, sometimes what they don't want. And often I ask too, are we aligning with your thoughts, your needs? Are we meeting those? And if we're not, help me to understand. And sometimes it's the wording to open that door for patients to just not yes and no, but giving them the opportunity to expand on their thoughts, feelings, because some of them, have been here for a long time and they've gotten to the point where they start to shut down because how we see things and how they see things different. But it's still looking at for them, recognizing, yes, not be the safest thing, but at the end of the day, patients still have their patient rights, and want to be heard. And when they're not heard, that's more often where we see them shut down, and thus don't want to interact with anybody anymore.
And what was coming to mind for me was that this is a topic that goes way beyond people like myself and like Jen, who, neither one of us is putting in IVs. Neither one of us is prescribing medication. But let's say you are, a doctor, a nurse, you're someone who has this substantial part of your practice being these concrete tasks that you're performing with patients. And you might think that everything that Jen and I are talking about today has no relevance to what you do. And I'm going to give one example of how it absolutely does have relevance, the example of non-compliance. So you have a patient, let's say you're a cardiologist, and you've been prescribing heart meds, and the patient is taking them once in a while or is not taking them at all. And that's frustrating. And you're starting to wonder, how can you even help this patient? You're prescribing the medications, they're not taking them. So the psychodynamic approach would be, even as a cardiologist, you're not a psychiatrist, but even as a cardiologist, when you're interacting with a patient, to be curious as to wondering why, what is happening on a deeper level. So when you're mentioning the medications, really trying to feel and to notice what are the emotions the patient seems to be having when you even bring up the subject. Mm-hmm. And then starting to ask deeper questions like, well, is it hard for you to go physically get your medications? Are there financial issues? Are there things in your family system that might make it difficult for you to do, to do these tasks? These are psychodynamic questions. Mm-hmm. And at the end of the day, you have the potential that your patient could actually end up taking their meds. Mm-hmm. So this isn't just sort of this dark night of the soul, odyssey, into the inner world. I mean, Jen and I love, but it also really connects to everything that we do in healthcare.
Mm-hmm. I mean, we always want to try and understand the world of non-compliance. We often hear that, and it is wondering, well, the whys, the whats, what else is going on in their life? Have they maybe have had bad experience even swallowing a pill? Have they seen a loved one have adverse taking this medication? I even hearing that too, some people, they listen to the TV. They, we are the professionals, but we need to get on their level to understanding of why taking their medication is so important, and trying to get to those biases of why don't they want to take it, or are they afraid that something may happen? That too is something that often happens, that they've had adverse reactions to other medications. Is this going to be another one?
So a lot of this is really just trying to get a total picture. And a lot of the work that Jen and I do, and a lot of the work in the psycho field, is not binary. It's not just yes or no. It's not just good or bad. It's a very complex total picture and spectrum of human life, because that's what human life is. So entering into what would perhaps seem to be simple, I prescribe meds, you're supposed to take them. If you take them, that's good. If you don't take them, that's bad. And that's it. I gave you the instructions, and it's your job to follow them. And that's true. And again, if there are reasons for everything, can we come to a deeper understanding of the patient, of who they are? Because we're not just treating, even if we are treating their heart in a very, very real sense, heart, we're treating the entire person that surrounds that organ. And that is the true deeper nature of the healing function that we all have. Do we want to take a moment for people to, because I've seen some chats flicker up.
Yeah.
Do you want to take a moment for people just to unmute and ask some questions?
Tom Trentafilo, Advocate Aurora, Chicago. Thank you for presenting. It's nice to kind of hear your thoughts. The challenge that I have, many of the things you're sharing is on an individual basis, like it's the patient and the physician. But some of the most challenging discussions I've had that gone really bad is the dynamics of the group, where either they have like forgetfulness, but there's forgetfulness, there's like some kind of syndrome, but when you kind of step away from it, you're feeling that it's not only the patient having that syndrome, it's like everyone that you're talking within the family. On the theories or methodologies, is there something that's moved from the patient to the collective, that network? And, so any thoughts about that? Like, are there thoughts about how to address the collective around the patient that may be misguiding them of what needs to be done?
Yes, I'm thinking of one thinker in particular, Robert Boyd, who was a professor at Madison. Tragically, he passed away before I got a chance to meet him. But he taught in the University of Wisconsin School of Education for decades. And he was, this is just one theorist, but he's in Carl Jung's thought to working with small groups in education. So I think the question you're asking is excellent. Another really very, very useful school of psychology is family systems theory that works with this. So I think what you're asking, it deserves a long discussion. But I would say a short answer would be, we could use many of the same techniques to, when we encounter a family, we encounter a group, which is really a small community, to use a lot of the same techniques to look at the community as a living organism, and to look at, so what are the roles, different figures within the family, within the group? Who speaks for the family? Who is influencing the person who's speaking? What are the power dynamics? How do we understand the nature of the interactions? Are people able to voice what, who they are and what they need, or are they not? So we can use these techniques, and it's a longer discussion. Erwin Yulom is another one, group theory, group therapy theorist. How do we use these techniques of trying to come to deeper understanding and doing it with, within a group, by looking at the constituent members of the group and how they interrelate? Because you're absolutely correct. A lot of the most challenging interactions, certainly that I have as a chaplain, and the work I do as a chaplain educator, are trying to understand more deeply what's going on within a group of people, what's going on the surface again, and then what's going on beneath the surface.
And two is really, I know with some families, it is the father who speaks on behalf of the family, and is or they don't believe in certain ways of medicine. And two, is it and kind of like a knee-jerk reaction where they're hearing this and they're having a hard time understanding the what, the why do I have to, why are you suggesting this treatment? How is it going to help me? How is it going to help my quality of life? You know, but before we even go there, sometimes it's letting the group kind of take a pause and take a moment and revisit, sometimes with the patient individually, of what are their wants, what are their thoughts and needs, and then talking with the family, because so often we see patients who their thoughts and beliefs are different than other family members, especially those in healthcare, in other professions, that they often speak for the group, sometimes without consulting with the patient and assuming what the patient wants based on, sometimes it's past beliefs, you know, and sometimes they really haven't had time to talk with the patient one-on-one, understand how they're feeling, what they're going through, because as a family member, they're trying to digest this new diagnosis and trying to cope themselves, and what are the options available. And so often that's sometimes when the anger comes out, because they're angry that they're going through this. They're angry that something is happening to their loved one, and that's where sometimes taking a pause and coming back and talking with them later on in the day, a different time, just to allow them to take in their heightened response and to come lower back down, so you really can talk with them in a way that they understand, because that's another too, is, are you understanding what your medical team is saying to you, is one question that I ask for patients, and because I want to know whether or not they fully understand. You know, sometimes they really do, and they can say verbatim what the doctors have told them, and other times there's really going on, and so you know, I can be that listening ear, and we can be advocates for our patients and further explanation in a way that the patient understands.
Excellent question.
Yes.
Any other questions?
Do you guys, Yoni in particular for you, is it typical for a chaplain to have training in this, that if we have a chaplain either in the hospital or associated with our palliative care team, and we run into a case that just feels crummy, that we've missed something didn't go right, that we could
Incorporate the chaplain in that follow-up meeting? Or is this something that is sort of beyond chaplaincy that maybe just some chaplains might have more expertise with?
I would say if a chaplain has been properly trained, so I would say no, by and large, if you have a staff chaplain who has been trained in the way that our profession does train us, they should have the capacity, obviously, you know, I mean, I'm someone who's coming to this with more years of experience and training than I would say maybe the average bear, but
Sure.
but by and large, staff chaplains have received training in these concepts of how to enter into an individual or a group situation, and to use ourselves with our knowledge and skills and our experience to perform, and then to have our own interventions follow from those assessments, but also to be able to guide the medical team in, oftentimes, especially the deeper aspects of what might be going on. Because as I tell my chaplaincy students, no one else does what we do. in the hospital. So we're privy to a lot of things that are latent content that are below the surface that other members of the medical team, because of training or time or role, are not privy to.
And me being the palliative care social worker, I have the time to be a part of these family dynamics that sometimes too, I can take some family members outside of the room and go somewhere else to kind of debrief them. And my role as part of the palliative care team is to help our patients and kind of digest and be able to understand what's going on, and then I help them to cope with what has been going on and the family, and thus continue to follow up with the medical team and let them know to what the patient's thoughts and feelings are. It's really a collaborative effort at the end of the day to provide the best patient care experience and to really understand our patients fully.
Because healing is holistic, healing is integrated. So we encounter a patient, I can't be the person who's going to understand in terms of the physical aspects of medicine what needs to be done. That is not my role, it's not my training, not my job. However, it is conversely equally true that myself as a clinician is the content expert, is the person who can best advise as to how the emotional, spiritual, and psychological aspects of the patient can be best addressed, assessed, and then what some of those interventions can and should be. So if we work together as a team, that total picture of healing can happen. If we don't, almost by definition, it can't. It's missing.
And so often, oh, go ahead, Marty.
It makes me worried about palliative care teams that are just one solo provider somewhere, and the limits of what that team can really accomplish and how they will probably struggle with the most challenging cases.
Indeed.
Because it is a team effort. We all bring our different specialties, time. And so it takes a while with patients to develop that rapport, that trust, that I think for us, not in and out providers, we have time to dig deeper and to be able to hopefully figure out some of the struggles that patients are going through in order to help them to fulfill their goals. So eventually they can be discharged safely back to their homes or wherever they are being discharged to.
The pandemic and the RSV and everything, what has been the role and what do you envision the role to be between now and 2031 in terms of using video encounters?
So that is topic of conversation. As a chaplain who was on the floors in and out of rooms during the entire pandemic. So I would say that before the pandemic, in many ways, it was a question whether or not we were going to proceed more fully in this way. And, is it a good idea or not? After the pandemic, it was almost a settled matter that it's here to stay. So the question becomes not so much, are we going to be increasingly using video as a way of interacting with patients? That ship, I think, has sailed. The question becomes, how can we, at least to me, the question is, how can we be creative and thoughtful about how to use technology so that we can interact with the patient on as broad a level as possible and preserve what was. I mean, the way I was trained was hours and hours and hours of sitting in person with my teachers who were teaching me chaplaincy and social work, and then hours and hours and hours with patients in the room with them face to face. So how can we use technology to replicate that? And that is a real challenge. I'm hopeful that it can be done more than maybe we feel in our anxious guts right now.
Yes, yeah, it's definitely here to stay, even as part of a social work role. And often, you know, for those patients out in rural areas that don't have the same access to the hospital and outpatient clinics, it's something that is a good tool. But again, it's so hard to see a whole person and their body language if we can only see their face. And the, you know, depending on the connection, when you're used to seeing someone from head to toe, and you know, you don't have so many distractions, or your patient doesn't have distractions in the room, to have their undivided attention, and to really see what's going on. Yeah, it's a positive and brings its negatives, just I think with anything else, but I know since we have been working with individuals face to face for so long, I think that it is hard changing to a screen versus in person.
The only thing I'll say is that it absolutely demands us to be even more committed to, when we're with a patient, that has to be our focus in our world. Because especially if what we can perceive of the patient is more truncated, then we have to be completely focused on what is happening with the patient and what we're picking up, what seems to be maybe changing, and what we can be curious about. When we're with patients, we better not be multitasking, because the responsibility becomes even greater for us to focus on this person, that it is our privilege, our job and our privilege to help them heal.
Great question.
Yes. So as we said before, next week, and I hope everybody comes back, tells their friends. Next week is going to be drilling a little deeper and looking at some of the more specific issues that come up in the work and the care. What are some of the more specific ways that human beings use, usually unconsciously, to cope with especially trauma and to survive? And so that'll be the focus of next week. A little bit less of sort of trying to look at the universe and everything, and drilling down a bit.
Lovely. Thank you, Yoni. Thank you, Jen. We'll see you
Thank
guys
you.
next week. All right. Adios.